So let's move back to heart failure emergencies. So I obviously, as I said before, this is an area very close to my heart because I think patients with heart failure need all the love that they can get. And last week we talked about heart failure's impact on the NHS, the fact that it is a colossal problem. And we talked about the different types of heart failure. So left ventricular systolic dysfunction, about heart failure with a preserved ejection fraction, and etc. So that's on the YouTube channel if you missed out on that. We also talked about the different medications for chronic heart failure. So for left ventricular systolic dysfunction predominantly. So again, please go to that if you want that, or how to manage emergency heart failure presentations. This week, we're going to complement that with the question, why do we get heart failure? And then I will talk about the different causes, a bit about etiology of heart failure, not in great depth, because I don't think that generally speaking matters that much, but you should have some awareness of that. And then I want you to take you through emergencies that might happen to a patient who happens to have heart failure, so that you know how to manage common things when patients also have weakness of their heart or heart that's not pumping very well. I'm also going to take you through some issues that you might get with initiation of ACE inhibitors or angiotensin receptor blockers and MRAs. Can you not see the one on there? There is, if you look in all the different talks that I've got, there is one that is on heart failure type 1, so it's definitely on there. I'll maybe see if I can find the link and post it at the end of the chat. And I'll also talk a little bit about palliative care. So why do we get heart failure? This is my pathophysiology of heart failure section, which I'm sure has you absolutely salivating with anticipation. So can you tell me why you get heart failure? Why is it that this heart failure is a syndrome? It's a constellation of symptoms where the cardiac output is insufficient to meet the demands, the metabolic demands of the tissues of the body. So why when the heart doesn't work at an energy deficit, does it end up getting steadily worse and failing? Why doesn't it just keep on going, albeit rather weakly? Why does it go on, and why do we end up getting heart failure? And the answer to that is that so it's remodeling, it's adverse remodeling, but why does the adverse remodeling happen? And it's because the body doesn't have a way of saying, my heart's struggling, I need to take care of it. Instead, your body says, my heart's not pumping as much blood as it should be, must be something wrong, like I'm dehydrated or I've lost a lot of blood. What I need to do is retain as much salt and fluid as I can and pump out adrenaline and try and get the heart working. And that's because we were designed, or we weren't, we were evolved back in the day when saber-toothed tigers were having undue contact with us and spilling claret. And we are all familiar with thirst and the need to rehydrate. And it's these processes that are brought on. So it's your kidneys which are stimulated by the lack of fluid, and the renal aldosterone angiotensin system is activated by decreased glomerular filtration rate, so you retain the salt and the fluid. It's the baroreceptors which tell the body that your blood pressure is low, and your sympathetic nervous system activates, and adrenaline pumps out, and other catecholamines, and your heart rate increases and it works harder. And so these processes cause the adverse remodeling and the ventricular wall tension and myocyte hypertrophy. So it's an inappropriate activation of natural pathways that are there to deal with natural problems that get out of control in heart failure and that cause the steady deterioration. And this is why the heart failure treatment has revolutionized over the last 20 years, and why we keep on getting more benefit, because it's this harmful process that progresses the patient along the road to worsening symptoms and ultimately death. And so if you block the harmful processes, which we get better and better at doing, we get better and better at preserving life and function. I won't take you through the different systems in detail, but if you want it, there's a picture there and you can freeze frame later on and have a look through it. And the baroreceptor reflex pathways are there. But the bottom line is just think kidneys not perfused well, so they work to retain salt and water. Blood pressure low, therefore you produce adrenaline. That's the sort of what you need, really. I like Star Wars, and I like to think about the dark side of heart failure as what I've just described. But there is also a light side, but unfortunately the light side is weak compared to the dark side. And in health, the natriuretic peptide system doesn't kick in until you're too far down the line. You're too far decompensated. Your BMP's sky high because the patient's really sick, and that's the natriuretic peptide that actually is trying to counteract these harmful processes, trying to make you pee out sodium and water, vasodilate, and suppress the adrenaline and the renal aldosterone axis. So there is a light side, but it's not effective in the normal situation. But sacubitril valsartan, this new drug which we've had about 5 years now, that augments the natriuretic peptides. The sacubitril stops them from being broken down, and so it enhances the natural protective processes. So that's the way this sacubitril valsartan works. So let's talk etiology. This is quite a nice little list. It is not remotely meant to be exhaustive. Now, if you remember from the types of cardiology last week, we have got heart failure with a reduced ejection fraction where the ventricle is weak, the left ventricle is weak. And we have heart failure with a preserved ejection fraction. Now, bear in mind that many of these causes can do both. So if you have ischemic heart disease, then if you've got ischemic tissue, that tissue tends to be stiff, so you can get heart failure with a preserved ejection fraction. On the other hand, if you have an infarct, that can cause naturally scar and weakness and left ventricular systolic dysfunction. Alcohol can do both. Cocaine, to some extent, can do both. Anabolic steroids, more typically left ventricular systolic dysfunction. Toxins are an important question to ask, because if the patient's an alcoholic, or if they're just drinking alcohol heavily, which so many of our patients in their 70s and 80s are, and you just would be astonished how much they put away. And they think drinking a litre of whiskey a week is perfectly normal because they've been doing it for 30 years. And they say to you, well, why? I've been doing this 30 years. Why would this be causing a problem now? So really important to ask about these because they are reversible. Ischemic heart disease, actually, if you've got a young person and it's been caused by ischemic heart disease, maybe we can make a difference. But it takes 10 years to show a mortality benefit from having a bypass operation when you have severe left ventricular systolic impairment and severe coronary artery disease. So it's, for most patients, it's not something that I really highlight hugely, although it is something I obviously would want to know about, particularly in my younger patients, and particularly if they might have just recently had ischemia. And I'd be thinking about secondary prevention as the big thing that I will make a difference for by detecting the presence of ischemic heart disease. So I do want to know about it, but it's not quite as critical as these very reversible things if they are the cause of the problem. High blood pressure can cause stiffness of the heart, or it can cause in the later stages weakness of the heart. You can have valve problems, that's valvular heart failure, and they obviously need to be fixed if they're the primary cause. And obviously tachyarrhythmias, bradyarrhythmias. So patients with fast atrial fibrillation, sometimes they're blissfully unaware of it, and it leads to a cardiomyopathy as the presenting feature. I don't want to spend too much longer talking about etiology because, as I say, while it's important to know why the patient has heart failure, it's the reversible causes that are the big ones that we need to be aware of. And we can do a cardiomyopathy screen in young patients. Don't do that in hospital. We get the chemical pathology team to do that for us as an outpatient. Don't let your consultants ask you to request it because you'll just get it wrong. A lot of the samples have to be put on ice. You'll end up missing out things that need to be done. Much easier. It's not an emergency to find out the cause of the cardiomyopathy. I've only once had one come back positive that I didn't fully expect to come back positive. So get that done as an outpatient, and it's well worth doing that to diagnose things like Fabry's disease, which every now and again we come across in our younger patients. So bear in mind that if you don't treat a patient with heart failure properly, I think that you ought to become part of this artwork. I love art. Let's have some cases. Imagine that you have a 55-year-old male. And his baseline is that he's MHA class 3, able to walk about 200 yards slowly. And he's presented with vomiting and diarrhea. You dutifully find out his past medical history, which is that he's had an ischemic cardiomyopathy for the last 8 years, and he's not been well in the last year with 2 admissions with heart failure. He's got a biventricular ICD in, which he's had for 5 years, and he's on really excellent heart failure medications, including a bit of diuretic, sacubitril valsartan, this medication which combines the thing that blocks breakdown of natriuretic peptides, sacubitril, with valsartan, which is an angiotensin receptor blocker, so it addresses the RAS system. And that's the top dose, so excellent drug, good dose. Eplerenone, which is like spironolactone, that's the mineralocorticoid receptor antagonist, at a very good dose. Carvedilol's a beta blocker, good for heart failure. Ivabradine, also good in heart failure in patients whose rate isn't controlled with the carvedilol. And dapagliflozin, a diabetes drug, which has been shown to reduce mortality and admission by about 25%. So excellent treatments for the heart failure. He's apyrexial, his pulse is 52, he's hypotensive, normal heart sounds and chest clear. And his bloods, he's got a creatinine of 162 and the urea of 24.3. So our patient is emptying uncontrollably from both ends, and he's got a poorly heart. What are you going to do about it? What are you going to do to treat this patient? Very, very good. So absolutely. First question, we need to know what his normal eGFR is, and we also need to know what his normal urea is, because some of these heart failure patients need to be run pretty dry in order to actually maintain euvolemia, and he might have had this sort of renal function for the last couple of years. Alternatively, it might be that he's very dehydrated. So absolutely, we need to know what his baseline is, although here you should be expecting him to turn out to be very dehydrated. So Samantha suggested we stop the diuretics on the basis of that. Yeah, do you just want to stop the diuretics? Is that going to be enough? Yeah, you want to rehydrate slowly if an AKI? So I've not given you quite all the information here, have I? You want to know, is he keeping anything down? Just how much vomiting and diarrhea is he getting? How many liters of fluid is he losing? If he's profoundly dehydrated and his blood pressure of 90/50, that could be his normal blood pressure, or maybe his blood pressure is normally 150 systolic. Probably doubtful, but it's possible. So is he hypotensive? The pulse rate, normally that would go up, wouldn't it? But just like in a GI bleed, you look to see if they're on beta blocker. He's on carvedilol and ivabradine, so he might not be mounting a increased heart rate in response to being profoundly dehydrated. So you can't rely on the pulse. So we certainly need to think about rehydrating this patient. But we need to know more about the vomiting and the diarrhea. We need to know more about the blood pressure, and we need to know more about the kidneys. And so if you have to rehydrate him, you don't want to overdo it, but you don't want to go too slowly. You want to reasonably briskly restore circulating volume if he's profoundly dehydrated. And that might well mean giving some IV. Here, I don't like giving salt to patients with heart failure, and his sodium's fractionally low. Uh, they might well have lost a lot of salt with his diarrhea and vomiting, so that might not be unreasonable to give in this instance. Generally speaking, I prefer to rehydrate with 5% dextrose if I'm going to. Or maybe if his renal function isn't actually that off baseline and he's actually keeping stuff down, you could simply encourage oral rehydration. But you need to get this right. It needs to be done really carefully, and that means a very, very careful assessment of the patient. What about the heart failure drugs? He's on a lot of different heart failure drugs. Do we want to hold those for a week and get his GP to review them? Or do you just want to hold off the frusemide and restart after 48 hours? Or do you want to hold the ACE inhibitors and the diuretics? Oh, I have to change that to ARNI. Clearly this slide is slightly out of date. I've changed the drug here without changing the other drug. So imagine ARNI, and that's an angiotensin receptor blocker and neprilysin inhibitor is what that stands for, ARNI. So what are we going to do with these drugs? So you suggesting that we should hold off the ARNI given the high potassium? If the potassium was above 5.5, I start to get a bit excited about it, particularly if they have got an acute kidney injury. Rather than rushing to stop the ARNI with hyperkalemia, would want to stop the eplerenone first. Here again, it depends so much on what the patient is actually like and what their baseline is like. If they are markedly hypotensive, they're feeling lightheaded and dizzy and blacking out, then they'll need to stop their heart failure drugs because they need the blood pressure to perfuse their brain and their kidneys, and they need to rehydrate. And it's a case of getting them restarted promptly. So you certainly don't want to choose A, because if you hold off all of his heart failure treatment for a week, chances are he'll be in hospital with heart failure. But if you just hold the diuretics, maybe that's not going to be enough to keep his kidneys perfused, and he's going to get progressive renal failure. So difficult decision, and it has to be based on all the combination of things. But I would be thinking about potentially holding the eplerenone and the frusemide, possibly halving the sacubitril valsartan. I'd be less inclined to adjust the carvedilol, and the ivabradine won't be dropping blood pressure. That would just be slowing his heart down. Sick day rules, dapagliflozin. Sick day rules in diabetes would probably mean hold off the dapagliflozin. Here, dapagliflozin makes you pee a little bit of sugar. In a diabetic, sick day rules, I'd apply them. This patient isn't diabetic, so it's not quite the same. But it might not be unreasonable to hold that off for 48 hours until things are better. The crucial thing here is that we aim to restart things as quickly as possible, and we may need to just be a little bit cautious in the way we go about restarting things. So, oh yes, Beth, thank you very much. So yes, dapagliflozin, that would be my take on that. Good. So let's imagine another patient, and please type if you've got any questions about that previous one while I tell you about this patient. So imagine this is the same patient, apart from I've realized that all my examples so far are male, so I've hurriedly changed one of the genders. So imagine this lady who has got exactly the same history as before, phones you, and you working in general practice and you're busy, you're dealing with the deluge of paperwork that you get from having to do general practice and you are also overwhelmed with dealing with the aftermath of COVID, but she phones you and manages to get through, and she tells you that she's gained 2 kilos of weight in the last 48 hours. And if you don't like the idea of imagining you're in general practice, imagine that you're in your surgical clinic seeing this patient ready to chop off a bit of her bowel, and she tells you she's gained 2 kilos in weight in the last 48 hours. What are you going to say to her? Let's let you have some options. So yes, she's still taking her meds. She's very, very carefully compliant with the medications because she's had a lot of admissions to hospital and she's had it drummed into her how important it is to carry on with pills. So you're, just to say that her have I got bloods in here? No, I haven't. So you can either say this isn't an emergency, book routine appointment and refer to Weight Watchers, or you can tell her that we're going to urgently check her renal function and increase diuretics. We could just observe for now and review in a week or so and see what happens, or you can admit to hospital and make it the cardiologist's problem. So question, is she symptomatic other than weight gain? Yeah, so that's an important question. So she's gained 2 kilos of weight in the last 48 hours. She isn't really that symptomatic otherwise. It might be a little bit more breathless at night. She might have slightly puffy ankles, but she's just not sure. So what do you think? Can we observe this and see her in a week's time to see how she's getting on? Bearing in mind that your clinics are overbooked and you're speaking to her over the phone and there's just no way you can see her anytime soon. So B, urgently check renal function, increased diuretics has been chosen. Somebody's chosen D, admit to hospital. Another person is erring towards B if she's otherwise fairly well. So the point here that I want to make is that if a patient with bad heart failure and multiple admissions is gaining weight rapidly. And people get a feel for what their weight is, and obviously it oscillates a bit day by day. But if somebody suddenly gains 2 kilos, that should really trigger you to think this lady could be about to have an exacerbation of her heart failure. And if you get in fast with an increased dose of diuretic, we can probably turn this around. You want to know what the kidney function is doing in this sort of instance because there probably is a baseline problem with kidney function, and if you are adjusting diuretics, you need to know what's having the effect and why. So I do think you need to urgently check the renal function, but actually I wouldn't necessarily wait for the result before increasing your diuretics. And it would be reasonable here to double the furosemide to 80 twice a day, or check what has worked in the past. But this lady needs action. She can't be observed because these patients can gain a kilo a day, and in a week's time she could be a stone overweight, and basically you're having to go for option D. So really important to spot. Another case. So imagine now we've got an 82-year-old lady who lives in a residential home. She can walk about 50 meters before she has to stop with general fatigue. But in the last month or so, she's got progressive severe peripheral edema. She's got a lot of comorbidities. She's had a previous stroke in 2010. She's a type 2 diabetic. She's got high blood pressure and COPD and renal failure. She's on some fairly typical medications for an elderly lady. She's on some furosemide and aspirin, simvastatin, metformin, amlodipine, and she's on some inhalers. She's apyrexial, heart rate of 90, blood pressure 120/80, and you can see her renal function here. So, let's put a face to our customer. And let's imagine she has diabetes, which I do hear is quite a bad thing, and she's got pretty bad chest, probably in your brain, not quite as bad as this one, but she certainly has boggy legs. So what are you going to do about this? Good. So you want to know what the baseline renal function is like. You want to know if the amlodipine is recent. She's not previously known to have heart failure. You want to think about stopping the EGFR. Yeah, I wouldn't worry too much about the metformin with this sort of in EGFR, but diabetes team might say different. Um, Amlodipine is, you want to know if that's new. Why do you want to know about amlodipine being new? Well, the answer I'm sure you're screaming out to me is that it causes peripheral edema. So amlodipine is a very common cause of swollen legs. Calcium channel blockers generally do it. So very often I saw one in patient in clinic today who just has swollen legs because of amlodipine. They NT-proBNP was checked and was 400 in an 86-year-old, so they were sent to see me, and it was, I was polite about it, but it wasn't a great use of time and resources. So remember that. BNP, NT-proBNP, we say less than 200 is normal. Over 2,000 identifies heart failure. Bear in mind that it's not adjusted by age, and it probably ought to be. If you had a 20-year-old with a BNP of an NT-proBNP of 200, I'd be a bit worried about that patient. An 80-year-old NT-proBNP of 400, that's a fairly normal sort of a value. So we do want to confirm that this is heart failure and check an NT-proBNP, but this could well just be due to the amlodipine. So stopping that if it's recently been started or recently been increased would certainly be on the cards. Anything else that you want to point out about this lady? So what do you think of her sodium? Yeah, she's already on a hefty dose of furosemide. I would say that yes, it is a fairly hefty dose of furosemide, particularly for somebody that I've said doesn't have a history of heart failure. Maybe I just wasn't aware of her past medical history of heart failure. Maybe she's been using that chronically because she's got boggy legs and she's got older, and it hasn't been clear cut that she's got heart failure. But it is certainly a fairly hefty dose of furosemide that she's already on. So what do we think about the sodium? So Samantha is saying sodium is low, probably indicating fluid overload. But isn't the sodium low because the frusamide's done it? Bit of both. Um, I would say that it's very unusual for frusemide to cause hyponatremia unless it's being used inappropriately. And here, either there's a different cause of the hyponatremia, or it reflects the underlying pathology, which here, with the severe peripheral edema, we're setting up to be heart failure. So in patients who have got bad heart failure and have a poor prognosis, often the sodium drops, and it's not that they've got a low salt level in their body, it's that they've got so much fluid diluting it. So this is a hypervolemic hyponatremia. And what we need to do is get rid of the sodium. So I'm giving you these as your initial options. This kind of a patient, sometimes we can manage as an outpatient, actually. I often see patients like this in my outpatient clinic. The thing that would determine whether or not she needed to come in, I don't like dealing with that sort of sodium as an outpatient, because if it does drop, then it's getting to the sort of range that the patient could do very badly. So if they are somebody I'd DNAR and have a palliative approach in that instance and not admit to hospital, fine, I'd manage them as an outpatient. But this patient, if I think that she's going to do okay with diuretics, I'd want to admit with that sort of sodium. But if that was better, we could give this lady tablets and stop her amlodipine and add in bendraflumethiazide to get the fluid out. Bendraflumethiazide is more likely to drop sodium, but in somebody who I think it's low because of heart failure, that would be the right thing to do to get rid of the fluid overload that's causing the hyponatremia. The appropriate dose of furosemide to give in hospital would be the oral dose converted to IV plus 50%. So you might start with 80 BD IV. That wouldn't be so wrong, but given she's on 80 BD orally, assuming that's chronic as opposed to it was increased a week ago, then 240 over 24 hours would be the right appropriate dose to start. Here, GTN would be completely wrong, because it's not going to get rid of fluid. It might acutely treat the heart failure a little bit, but it's no longer part of NICE guidance. It would be completely wrong here. Fluid restriction doesn't really help very much in heart failure. There's a trial in the New England Journal, one of those trials I wish I'd done because I could have done, and that showed salt and water restriction just made patients thirsty. But if she was drinking 3 or 4 liters a day, I'd fluid restrict her, but not if she's drinking a normal amount. Giving sodium is the wrong thing here. And I've never needed to send a patient for ultrafiltration, but it is an option for us. If she were on spironolactone, that would certainly be a drug to stop, but she's not on spironolactone, so don't worry about that statement. What about starting her on a proper heart failure drug? So shall we get her on some ramipril and bisoprolol and take the opportunity of her being in hospital to get her on diuretics? Or do you just want to give the ramipril or just give the bisoprolol? Or do you want to hold off proper heart failure medications until we get the hang of her fluid overload? What do we think? Yeah, very good. Bisoprolol not acutely due to risk of decompensation. So we want to first diagnose here that this is heart failure. So I want an NT-proBNP. I also want to know what sort of heart failure this is, because if it's heart failure with a preserved ejection fraction, then actually these medications aren't indicated other than for blood pressure control, and they're certainly not indicated acutely. But if it is left ventricular systolic dysfunction, then obviously I want to take the opportunity to get medications on board. But this lady is going to be here a while, and there is a danger that she doesn't respond well to diuretics. That low sodium is a warning sign that her prognosis is not good, and sometimes it is better to hold off the medications pending diuresis. So the answers here are, if you're going to start the bisoprolol, start at 1.25, and certainly don't start until you've achieved the beginnings of a diuresis. So A and C are out. B or D, either is probably reasonable, but I might veer towards D. So 72 hours later, imagine that you're an FY2 and you're being called by your FY1. The lady's passing good amounts of urine and her weight's going down, but she's hypotensive and her EGFR has dropped to from 45 to 20. So imagine you chose option B and you started an ACE inhibitor. What are you going to do? Do you want to stop the ACE inhibitor and continue diuretics? Or do you want to stop the diuretics and continue the ACE inhibitor? Imagine this lady has severe left ventricular systolic impairment. Or do you want to stop both? Sorry, B is stop both. C is just stop the diuretics, continue the ACE inhibitor. Or do you want to transfer to cardiology so we can give some IV dopamine and then carry on the ACE inhibitor and carry on the diuretics? So option A is being selected. We want a fluid status assessment. Yes, we certainly want a fluid status assessment. Do we think the ACE inhibitor has caused acute renal failure? Yeah, it can do. It can do. But do we think it has? Renal artery stenosis, yeah, she's 80. She could have renal artery stenosis. It would have to really be bilateral for it to be causing renal failure from that mechanism, but maybe. So how much urine is she passing? If she's peeing 2 liters a day and her weight's going down by a couple of kilos a day, then we're overcooking this. If she's centrally dry, we're overcooking this. We need to reduce the diuretics. If, on the other hand, she's passing about half a litre to a litre of urine a day and losing about 1 kilo a day, then we're on target. That's what we want. So we're not over-diuresing. The patient's hypotensive. So we want to stop the ACE inhibitor because she's hypotensive, because we need the blood pressure both to perfuse her kidneys and to allow for the filtration. It would be very unlikely that she's hypotensive and still passing good amounts of urine. So this is a slightly odd history if anybody tries to give it to you. Probably she's now no longer passing good amounts of urine because she's overcooked it beforehand. So we probably want, if we want to stop the ACE inhibitor, and if we've overdone the diuretics, we'd want to potentially hold those, maybe even rehydrate her a little bit and then start again. If she's not diuresing too much, then we would want to transfer to cardiology, give IV dopamine, and just very carefully monitor this, because here, if we can't diurese her because of the failing renal function, then that's a sign that we are not going to win. Because if we have to stop the diuretics and give up with trying to clear the fluid, then she's going to do very badly. So we want to carry on if we at all can, but or if we cause her renal function to crash further, she's not going to be a candidate for dialysis. So that would be curtains for her. Acute renal failure with ACE inhibitors. This is not a wonderful slide. I must edit this a little bit, but ignore the writing in white and just look at the one in sort of the light green. So this is data from SOLVED, and SOLVED was an early trial of ACE inhibitor, of enalapril, of about 6,000 patients, and it only excluded patients with pretty severe renal impairment. And it found that there was a trend, but it wasn't a significant trend, to a more than 20% decrease in eGFR from baseline at 2 weeks with enalapril versus placebo. So what that means is that, an odds ratio of 1.2, lots of patients on placebo ended up with renal impairment. Both, there's slightly more on enalapril, but only slightly more, odds ratio of 1.2. And 10% of patients in the trial had an over 20% decrease in eGFR by 2 weeks. So it's a very common finding in these patients in SOLVED, and that's because there were sick patients in this trial. But this is a sick lady that we're dealing with here who's being diuresed. So it's very common for these patients to drop their renal function, but don't immediately blame the ACE inhibitor. And bear in mind that it's going to reduce her mortality by 30% if you can get it restarted in her. So don't then deny it once you've got her stable. You need to retrial it. So if you're starting an ACE inhibitor in a stable patient, monitor their eGFR, and if it drops by over 20% at 2 weeks, consider stopping the ACE inhibitor. But also consider other causes of acute renal failure, and consider getting the patient stable and then trying it again. Or if you can't use it, isosorbide mononitrate and hydralazine are an alternative, but it's very hard to titrate those to good levels. So I'd much rather try again with the ACE inhibitor. Prescribing spironolactone to a patient with heart failure. It's a really good drug, reduces mortality by about 20%. So really good drug, also improves symptoms, reduces hospitalization, but it needs monitoring. If you don't monitor it and the patient dies because of hyperkalemia, then that would be negligence. So you can't just start this in a patient and forget about it. So really important to give it because it'll make the patient live longer, but also really important that it does get monitored. And the heart failure team will watch out for these blood results for you if you're starting it in hospital and you need it checking post-discharge. So just let the heart failure team know and they'll add it to their board. Thanks, Lizelle. I'll come back to you in a second. So eGFR, if the eGFR is over 50, we could start spironolactone at 12.5 to 25 milligrams once a day. And then we double to 25 milligrams once, or you can give 50 milligrams once a day. After a month, the potassium remains less than 5. If their eGFR is 30 to 50, then start 12.5 alternate days or once a day. And then you could go up to 12.5 daily or 25 once daily at most if their potassium remains under 5. They need to have their renal function checked 1 week after starting, 4 weeks after that, and then every 3 months if they're on an ACE and ARB, as well as the spironolactone. If potassium is 5.5 to 6, you halve the dose. If it's over 6 or the renal function is deteriorating, then stop. So if the potassium is 5.4, you can just carry on. It's only if it's 5.5 to 6 that we halve the dose. So we tolerate mild hyperkalemia. Spironolactone has got an indication in heart failure with a preserved ejection fraction. The TopCat trial studied it, and it was only when we excluded people from Eastern Europe that we felt they'd been paid to join the study, and it wasn't done quite as well there, wasn't quite as clean a cohort of patients. So if we exclude them, we find a significant benefit from spironolactone, but it's a modest benefit. So I do use it in heart failure with a preserved ejection fraction, but I don't tend to start it in people with borderline kidney function. I don't tend to push it as much. TopCat trial, it was added in 90% of patients to ACE or ARB. So you don't stop the ACE or ARB just because they're not indicated in HFpEF. That wouldn't be following the trial. So really should be adding it to treatment. So it does need quite a lot of monitoring. So I'm less pushy in heart failure with a preserved ejection fraction. Brilliant. So now for a change of pace. We are obviously still celebrating the Leicester victory in the FA Cup. Well, let me interest you in Belgian Football League. This is Roeselare, and this is Anthony van Loos, and it's just approaching half time. And Anthony van Loos, I want you to watch him very carefully as he walks back towards his side of the pitch and dies, just like that. Did you see that? That flick of his legs? That was his ICD firing, and he's ready to get up. Watch that again. Just look how he goes down. No warning whatsoever. One moment all's fine, the next minute he's out like a light. The ICD fires. Takes about 5 seconds, up to 10 seconds for it to charge, and then a few seconds later, up he's ready to get. That's how wonderful an ICD can be in the right patient. But the problem is we put a lot in that never fire, and it can be really difficult to know who the right person is. The main gatekeeper test is left ventricular ejection fraction, and that's not a very good gatekeeper. So most of the people who die of sudden cardiac death don't have weak hearts. But if we put it in everybody who'd had a small myocardial infarction, then we would be putting in loads that never got used. So it's really, we're not very good at stratification for ICD. But do think about it in your patients with weak hearts and ask us if you're not sure. Please don't ask us in every 90-year-old nursing home resident, because clearly it's not appropriate to put something that costs 10,000 quid into that sort of a patient. But patients, I wouldn't have a strict age cutoff, but if they're under the age of 75, I'd certainly think about it with severe left ventricular systolic impairment. What about end of life with a device? So lots and lots of patients have got ICDs, and in one of the talks, I've got as my sort of image at the start, instead of an ECG, I've got an X-ray that allows you to know if it's an ICD or just a pacemaker, because it's really easy to tell them apart on a chest X-ray. But if they've got an ICD and they're dying, 1/3 of patients will end their life with ventricular fibrillation or tachycardia and end up potentially getting a storm of shocks from their device, which are completely fruitless because they will just keep on going back into VF, and they'll potentially die with a storm of electrical shocks from their device, which is, if they're still conscious, potentially deeply unpleasant, and it can be very unpleasant for families as well. So no patient should die with an active ICD that needs to be deactivated. That can be done wirelessly, and it can be switched back on again wirelessly. Doesn't need an operation. The pacemaker team can respond very rapidly to these patients and go to see them at their home to get it switched off. they will leave on the pacemaker function. So the patient's not going to die suddenly unless they're unlucky enough to go straight into VTVF, but it's likely that they will slip away peacefully if you can deactivate the device as opposed to having lots and lots of shocks. So do remember that. Do identify if your patient has an ICD. Pacemakers, on the other hand, are not usually deactivated. That's partly because it's not straightforward to do, partly because it's not wonderfully ethical. I would feel deeply uncomfortable being responsible for the patient dying in front of me. Um, but it doesn't normally happen like that. Mostly, if I deactivated a pacemaker, even in somebody who appears to be pacemaker dependent, they would probably keep on blacking out and feel absolutely awful, but their heart would probably tick along at a rate of about 20 and keep on pausing. So it's we do not deactivate pacemakers. Every now and again, I get asked by ITU to deactivate a pacemaker because they want a bed, and I generally resist that. I've yet to actually switch a pacemaker off, but I have known it to be done at other centres. So ICDs always need to be switched off. Pacemakers basically never need to be switched off. There's a great deal of other stuff we could talk about in terms of palliation. So we can help with symptoms of breathlessness with a handheld fan. That's great for breathlessness because they can control a flow of air on their face, and that really helps feeling of air hunger. If you give them a fan at the end of their bed, they just feel cold, but a handheld fan they can control. Or Oromorph, 1 milligram twice daily and as needed half an hour before exercise can also be very useful for patients chronically breathless with heart failure. So lots and lots of stuff can be done to make symptoms better. Wonderful. So that's everything I wanted to say about heart failure this week, paired up with last week. So